while we're waiting for people to sign on, just like to say a few quick words, since we have a lot of things to actually get through, which is good, So my name is Baschat. I'm the center director for, the people that don't know me. And today is our first symposium of our center research and work that we have been able to do with the support of our patients. This year was the first time that we hosted a patient picnic again after a break from COVID. And I think it was really great for us to sort of engage again with the families and sort of have the personal contact. And, I think all of us noticed how much we missed that actually. And one of the things that came out of that for us was also to say like, well, you have given a lot to us that has helped us to do research, develop some new findings and all that. And many families have asked us actually at the picnic, what are you doing? What are you working on? So we figured maybe it's a good idea to actually go over all the work that we've been able to do. So that's the purpose of the symposium. So we're going to have 4 sort of overview presentations, and then the intention is to have a Q&A at the end. And if you have any questions that you want to put into the chat, we won't be able to answer them during the presentations, but we will take note of them and we try to address them at the end. As far as the housekeeping things are concerned, is that it would be great if you just keep your phones muted during the presentation, and the presentations will be pre-recorded and they will be available in about a week's time. So, and with that, I like to just move it forward, and I'd like to ask our colleague, Dr. Mara Rosner, who's assistant professor, one of the attendings at the center, to talk about the amazing work that she has done with the Twin Lab and the Twin Research Initiative. Thank you.
Okay, I'm gonna share my screen. Let me know how I do. Are you guys seeing the right stuff? Cool. Okay, so like Dr. Baschat said, I'm Mara Rosner. It's really great to see how many patients have joined today. And I'm here to talk with you about monochorionic twin research at the Center for Fetal Therapy. Monochorionic twins are twins who do not only share a uterus, but they also share a single placenta. Like most siblings, they often do not share evenly. Differences in sharing of blood across the circulation and in sharing placental real estate, as depicted here, can create a variety of problems, such as twin-to-twin transfusion syndrome, and many of which of these problems require interventions that we do at the center. So as you may guess, research into monochorionic twins is a pretty large operation because we take care of so many monochorionic twins. And therefore, we've created actually an entire laboratory specifically for the purpose of facilitating research on monochorionic twins. This is a screenshot from our weekly lab meeting. We started with only 3 students in 2020 and have since grown now to 10. Members are actually mostly undergraduate students at Hopkins. And you may be wondering how undergraduate students can work with such complex data. And these students undergo extensive onboarding process with hours of clinical training on monochorionic twins, training courses and certification on ethical research practices, patient privacy training, and extensive training in the use of our electronic medical record and our database. We're supported by administrative and research staff at the center. You can see Denise over here, our senior research nurse, and Melva, our admin. And we also have fantastic dedicated IT staff as well, or support our staff. So speaking of the database, the REDCap is an advanced database structure that allows us to maintain patient-level data within the confines of a secure data set. Patient data is organized as the pre-referral ultrasounds, pre-operative ultrasounds, interventional information about the procedure if patients have one, pregnancy follow-up, infant follow-up. And at the moment, we have 1,129 patients and counting entered into the database. So it's quite a lot of data. One of the first things we wanted to do with our data was to understand how we're doing. And we are happy to find that our survival data is better than what is anticipated based on the published literature. So we're very pleased to see that. And because we have created a large research infrastructure, we've also adopted some lofty goals. We want to push the envelope with research into cutting-edge surveillance strategies, investigating questions that help us learn how to refine our intervention techniques and outcomes. We want to look into racial and socioeconomic disparities and issues patients have with accessing our care, and to discover new and enhanced predictors of disease and outcomes. We want to reshape the conversation about monochorionic twins and explore long-term outcomes after interventions. So next, I'm going to share with you some of our exciting findings that we have discovered so far. For one of our first projects on twin surveillance, we presented evidence that performing blood flow studies in seemingly uncomplicated monochorionic twins can identify issues that might be able to save lives. In looking at interventional techniques, we found that bleeding from the trocar site at the time of laser surgery can predict bleeding even later in the pregnancy. And this discovery led us to work with the bioengineering team at Hopkins to design better trocars for our interventions. We discovered that the rare patient who might need a second laser surgery, that outcomes are actually not worse for those patients. We were happy to see, and we also were pleased to note that survival after a laser in triplets is similar as survival in twins. We next looked at access to care, and we were sad to learn that our non-white, uninsured patients have lower survival after laser. This is obviously just the beginning of the story, but we are opening up the conversation and working towards change. Sorry. In terms of disease predictors, we have discovered that first trimester findings can identify a pregnancy at risk for development of twin-to-twin transfusion syndrome with a small twin. We've also learned that the small twins are at the highest risk for not making it through the laser or having more severe complications if they do. Our next project was inspired by a parent question as we explained to them that the smaller twin was at this increased risk. The parents started asking us if the fact that the twins were the same size a few weeks ago made a difference. And we actually learned that it does. We see that twins who are of a similar size weeks before they come to see us, even though by the time they see us at this time point, the twins are very different in size with a small baby, those are the twins that get better after their laser and are born of similar size yet again. However, it's this group who actually looks the same. They all look the same when they see us at this time point, but it's this group of patients that a few weeks before their TTTS diagnosis were already different in size that go on either, like in this red line, to lose their smaller twin after laser, or to continue to have a large disparity between the size of the twins at birth, which can lead to more complications. This finding is actually completely novel because no group that we know of has ever looked at the size of twins before TTTS develops as a predictor of how things will go after laser. This helps us understand the pathophysiology of TTTS better and will hopefully lead to even more new discoveries and better understanding about the diseases we treat. So in summary, we have over 1,000 records in our database, and that data entry is ongoing and obviously very large amount of data. We presented 11 papers at national and international meetings. We have 4 manuscripts in submission and 2 manuscripts in progress of being written, and multiple impactful discoveries so far. These are members of the lab together with the center staff doing what they do best, presenting literature and data. And then this is us at some of our social events, enjoying pumpkin carving with my family and playing with my dog. So the future is bright, I think. One of the things I'm very proud and impressed with is how the students at the lab have helped create a lab infrastructure that supports our durability and ongoing refreshment with new members as students graduate and move on to other things. This process is also definitely reinforced by student success. I'm pleased to say that we have 100%, 2 out of 2 med students accepted to medical school that they applied for. Coming from the lab, we had a medical student in the lab receive a scholarship award for her research. We've placed 3 students at successful positions as research assistants at Hopkins for their gap year, which will help their medical student applications, and 1 current med school applicant. Of course, we do have challenges. Our biggest challenge is data extraction from the REDCap, which is complex and requires significant expertise and statistical support. Manuscript editing and submitting manuscripts requires a lot of work. And so those are our biggest challenges. In terms of future research goals, we have many. One important research goal I wanted to highlight is our goal to do more research into neurodevelopmental outcomes, which is a challenge because unlike in some other countries, neurodevelopmental follow-up is not mandated by our government and so is very variable. So lots of work to do there. And I'm just so grateful to everyone who's involved in the lab. And that's it. So I think we're going to move on to Dr. Miller, who's going to talk about spina bifida, and I'll take questions later. Thank you.
Thanks, Mara, for that awesome summary of the lab. That was great. So, for my topic, I am going to share with you, let's see, about the journey of the development of our maternal-fetal surgery program for spina bifida here at Johns Hopkins. And among many things that we do, this is one of the programs that I direct. Are you able to see my slides? Okay. All right, awesome. And so fetal spina bifida happens when the spinal cord doesn't close within that first month of pregnancy. So before a woman even realizes that she's pregnant, and this causes 2 major things. So with the nerves of the spinal cord being exposed, that of course can damage the nerves. And as the baby grows, that area is pretty stuck. And so as the baby gets longer, it pulls on the brain and the spinal cord, which prevents the outflow in normal circulation of fluid that's created in the brain. And that leads to a condition called hydrocephalus and can cause damage to the brain. The higher the level of the lesion is the bigger impact on our motor function. And that increased pressure in the brain from hydrocephalus is the leading cause. And most children will need something called a shunt that diverts that fluid after birth. And the leading cause of death in children with spina bifida are malfunctions with shunts. So it's a really important target with fetal intervention. One thing that we know is that fetal surgery for spina bifida has some really important benefits. So by closing the spine during pregnancy, we know we can lower the risk of shunt by about half, and children have better neurologic outcomes. And the classic way that this is done is by making an incision on the abdomen, exposing the uterus, opening the uterus and exposing the baby, and doing that closure directly. As you can imagine, having a scar on the uterus can cause some significant problems during the pregnancy for the mother and lead to increased morbidity. There's a higher chance that babies are born early, and that scar can be a problem in the current or even the future pregnancy. So being maternal specialists and the mother always coming first, one of our major aims is to decrease the risk of that scar on the uterus. And so the alternative is to do this in a minimally invasive approach where we use cameras actually to look into the uterus and perform that closure on the baby. We remove the fluid and put carbon dioxide gas on the inside to create that dry working environment. And in the very early days when this technique was first described, there were some significant concerns about the exposure of the fetus to carbon dioxide. And most of that work was done in sheep. And as you can see, that's been quite some time since those concerns were raised. Well, I don't have to tell you, there's some significant difference between humans and sheep, not only when they're born, but they have very different placentas. And so I'll come back to that in a little bit, or why we question those concerns. We have a lot of really great guidance also on what is required to have a comprehensive program for fetal spina bifida surgery. And so it not is just a group here in our center at Johns Hopkins. It requires a big team of our radiologists, our anesthesiologists, also our pediatricians in neonatology, pediatric neurosurgery, are our co-surgeons. And we also have a long-term follow-up care with our Kennedy Krieger multidisciplinary spina bifida clinic. And so all of those components are represented within our program. And when we were first initiating bringing fetoscopic spina bifida closure to Hopkins, there were a lot of things to consider. So first of all, every lesion looks really different. It isn't one area of the anatomy that can be abnormal in one particular way. Doing this type of surgery is something completely different from any standard laparoscopic procedure that you ever are taught in your surgical training. And it requires us to coordinate between two different subspecialists. So between a fetal medicine specialist as well as a pediatric neurosurgeon in order to achieve this closure. And when we were starting here at Hopkins, we also had no sheep in the budget. So that was important to remember as well. And so when we first were thinking about bringing spina bifida closure here to Hopkins, that really started in the beginning of our center. So we've been thinking about this, looking at different techniques for fetoscopic spina bifida closure, beginning even from 2008. When we first came to Johns Hopkins in 2014, that initial meeting happened within the first 2 months that we were here. This was a big initiative for us. And so first thing that we had to do is make some friends, build that team, find some space in order to do all of the things that we needed to do. And we decided, and we had to have a lot of meetings in order to bring that team together and create that multidisciplinary group. And we decided in order to do that, we also were going to embark on a plan of doing our multi-specialty training through the process of modeling and simulation. And our first case was in 2017. So this was a 3-year process. So I'll show you kind of what that looked like. So in the beginning, we really refined our ultrasound assessment of spina bifida using 3D ultrasound and obtaining images that can rival CT or MRI scanning. So we could see where that lesion started, what the surface looked like. And Dr. Majid Fadden here in the front is our fellow who described that technique in the literature. And we decided that, as we mentioned, we had no sheet to practice on. We decided to use our skills with 3D ultrasound in order to create 3D printed models in order to practice for this surgery prior to implementation. And at the time when we started this technology or this ability to do that did not exist from ultrasound. And so we received a small grant from the Fetal Health Foundation in order to use that workflow. And we had some important lessons. So the first thing was to really start with something easy. You can't start with engineers and images and ultrasound of spina bifida lesions. So we began first with basic shapes, squares, spheres in a gel phantom. So we can learn how to actually image these things and create these volumes. And when we did that, we also started with faces because that's something that is easily recognizable to everyone on the team. And for quite some time, our 3D printing station lived cozily behind my desk. And that was really important because when you're doing 3D printing, just like children, you have a great plan, but it doesn't always go the way you plan from the beginning. And so you can give the 3D printer the instructions, but you have to verify that it's going to do what you ask. Ultimately, we were able to get there. And so we were able to take those 3D ultrasound volumes, create them into 3D printable models. And we use them actually in this very high-tech fetal model that you see here, small baby from Amazon, placed an artificial skin over top and practiced in our in this also very fancy simulator that was created in Dr. Baschat's garage. And what was important, this allowed us to really bring our team together to practice all the individual steps. And we learned a lot of things from that exercise. So first of all, it worked really well. Although it was simple, we got a lot of value out of that project. So we were able to do this and see that it really correlated with what we saw in the surgery. Now, as you can imagine, it takes longer to actually do that procedure in the operating room than it does in the station. But over time, our surgical time did decrease and very much was in line with the other published series for this type of technique. Now, coming back to the sheet, we had the questions about how carbon dioxide, in fact, impacted the fetal blood gas in the circulation. And we were the first group to actually check. So in this surgery, we actually took samples of the fetal blood from the umbilical cord during these surgeries. And what we learned is that there is no major change in fetal blood gas values. And so we were the first group to ever report that in human experience. Now, some other people observed the same and in an additional series, and so that has been replicated. Now, we wanted to take our 3D printing work to a little bit higher level. And so instead of doing that just on that plastic doll that we have, we wanted to create an actual simulator. And so we started with a 3D CT of a 23-week fetus with Spina Bifida. And then with some computer modeling and changing that around, we were able to actually create a modular system where we have a fetal host model and some set-sized inserts of about 10 or 11 different lesions that you can just interchange and place in there in preparation for our surgical practice, which we still do periodically among our team. And this is how it actually looks in the operating room. So it's a big endeavor. It's a really big group, and we've come a long way, and we were able to publish our experience in this process so that hopefully others can replicate it too. And so for our story, in our first 20 cases of fetal spina bifida surgery here at Hopkins, we're seeing the same results. So our children have a lower rate of shunt that's even better than the gold standard. And we have more children that are walking. So we're really proud of where we've come so far. When we combined our experience with the other groups that perform this type of surgery within our international consortium, the outcomes are also similar. So similar gestational age at delivery, similar need for shunt overall in the whole category, and a third of patients were able to have a vaginal delivery versus requiring cesarean section. So we've still got a lot of work to do. There's a lot of innovation still coming in this space with the whole goal to improve the outcome of our individuals with spina bifida. And even though having a child with spina bifida and having this type of fetal surgery can be very different, there's still a lot of joy that can be had. And kids with spina bifida are truly amazing. Thank you for your attention. So I'll pause for a minute, and I guess we can stop for some questions, or shall we continue?
I don't see anything in the chat yet.
Okay.
Or I don't, if there's no questions, maybe we should just continue and have the Q&A in the end.
Sounds good.
Well,
so,
yeah.
Oh, go ahead.
Yeah. No, you go ahead, ladies first.
Okay. So next, I'll introduce Dr. Michelle Kush, our colleague who is heading up the Biobank.
I'm going to share my screen. Give me one moment to get everything set up here. Okay. So you should be able to see my screen. Just need to presenter mode. Give me one moment. Okay. Well, again, I'm Michelle Kush. I'm one of the physicians here in the Center for Fetal Therapy. And again, I'd like to thank you for sharing your time with us today. And I'm going to speak to you about our plans to extend and expand our existing fetal biorepository. So biorepositories or biobanks first appeared in the literature around 1996, so fairly recent. They're often referred interchangeably as registries or repositories, biorepositories, tissue banks, and while there are subtle differences between those exact words, they're used very fluently between each other. But really the goal behind a biobank is to receive specimens from multiple sources and maintain them over time. Specimens are human biological material that are attached or connected to information after obtaining consent. And then these samples as well as this data are held safely and protected. But again, the focus of a biobank is to sort of control access to and the use of these specimens, but it also allows for use of specimens by multiple individuals for multiple purposes, and that purpose evolves over time. So what exactly is a biospecimen? It really is any material or fluid or tissue that you can obtain from a patient or a research subject. Our focus is the discard samples, which are samples that are routinely obtained during our procedures but they're not used for clinical or diagnostic purposes. An example would be during a blood sampling. It's a small amount of blood that's obtained prior to drawing the actual sample, or excess fluid or amniotic fluid that's removed during a laser procedure, excess fetal urine, or any other samples that are obtained but not routinely tested. Storing these specimens allows for future investigation and diagnostics. So the main components of a biobank are really broken down into two main categories. There's the biomaterial, or the sample, which is collected, processed, stored, and eventually distributed. And then there's the data component, which is collected, again, after informed consent is obtained, confidentiality is maintained, and it's held in a very secure location. Doing a biobank, it allows you to create a process for research projects. And in simplest terms, you consent the patient, you obtain your sample and your information, you process and store both of those securely. And then in a controlled fashion, you design investigations which yield results and ultimately publish these results to expand the fund of knowledge on fetal conditions. Each component of this process has certain requirements, and many individuals are needed to fulfill each step. One individual may be able to do a few, but not one person can do all of these steps. So you develop a core group of individuals to meet each of these requirements, as well as have institutional support for accounting and regulatory compliance. Current challenges. Well, the biggest challenge is that there's a lack of high quality, appropriately collected and stored, as well as annotated fetal specimens. And this is universal in the realm of fetal medicine, not just unique to us. And this is really why we would like to expand upon our currently stored samples, including our discard specimens. And again, while they're not being clinically utilized, they could provide insight and answers through future investigations and testing. And this slide just highlights again the need for more fetal and pregnancy-focused investigations. This represents PubMed citations since 2003, so 20 years of literature. The green circle represents the number of publications that included biorepository or biobank, and you can see there's 31,000 publications. But when you combine biorepository or biobank with pregnancy, there's 1,000. And if you combine biorepository and biobank with fetus, there's 48 in the past 20 years. So by expanding our current biorepository will ultimately lead to the expansion of knowledge and contribution to the body of literature on fetal conditions. Which leads us to our goals. So our goals really are to invest in the future, to build upon our current bank of fetal samples, and it allows us to develop a unique collection of biologic samples from rare fetal conditions, which would otherwise be discarded. And being a fetal therapy center, we are able to collect more of these samples than outside units would be able to. Our goal is to ultimately expand knowledge and understanding of fetal conditions, which may, in partnership with bench or clinical or basic scientists, as well as industry, the development of biomarkers, which can really help us identify or refine diagnoses, ultimately leading to precision medicine and personalized treatment plans. Recently, we have acquired a -80-degree freezer. It's located here within the center and currently holds samples from our prior studies and our ongoing samples. We're really excited to have this in our center, and it's really going to facilitate the development of our discard sample collection. And in summary, our goal is to expand upon our current bank of samples, creating a really robust biorepository of high quality, appropriately collected and stored fetal samples which would otherwise be discarded. And biorepositories are at the heart of precision medicine and personalized treatments, which are really the future of medicine. And pregnant patients, fetal patients really should be part of this exploration, and we're really excited to be part of that. So that concludes my talk. And I don't see any questions that popped up in the chat. So my next job today is to introduce Dr. Baschat. He and I have worked together for quite a long time, first as residents, then as fellows, now as attendings, and I'm lucky to have him as a mentor as well as a friend.
Thank you very much. You didn't show all the party photographs, right? That's okay. All right. Well, I wanted to talk about congenital diaphragmatic hernia, which is basically a condition that affects, maybe 1 in 3 to 1 in 4,000 pregnancies. It is a condition that is caused by a hole in the diaphragm of the fetus. And what it does is it allows abdominal contents to go into the chest wall. And although that defect is pretty easily surgically fixable after delivery, what happens prenatally is that the lung compression, because of the abdominal contents in the chest, seriously impair lung development. So by the time the baby is born, the main issue of diaphragmatic hernia is really that will the baby have lungs that are well enough to function to survive? Over the years, we have refined our abilities to actually figure that out prenatally. And there is the latest assessment technique that we use is what is called the observed to expected lung to head ratio. And what this sort of is it measures the size of the lung of the baby and compares it where the expected size should be. And there's a very clear correlation with the smaller the lung as a fetus, because of lung compression, the more likely it is that the defect is a large defect, and the more likely it is that the survival is at risk. So in Europe, a technique was developed that allowed the temporary blocking of the fetal windpipe, the trachea, before the baby is born. And what this does is it blocks the lung fluid from getting out, and by that it causes overgrowth of the lung. And so it reverses partly the process that's actually caused by the diaphragmatic hernia. So this is like a latex balloon that's brought in with a fetoscope. It's inflated, it's detached, and it can be removed. And the first study that looked at over 200 patients actually showed that when you do that procedure, where you basically go into the baby's mouth, you find the back of the throat, you go into the trachea, you deploy the balloon. And this is an actual procedure that we've done here, and it's also, available on our website for parents that are considering this. Basically, what happens is that the lung that is quite small basically starts to significantly expand in size. And that size expansion almost doubles the size of the lung. And then you got to remove the balloon, because when a baby comes out, the baby needs to be able to breathe. And after the balloon removal, most of the lung size, most of the cases have a decrease in the lung size, but the lung size still ends up being significantly larger than where it started. So if you start at 30%, you're more likely to end up at 50%. And basically, what the study showed is that the observed survival for severe diaphragmatic hernias, both on the left and on the right-hand side, were much higher than expected. But the risks of the procedure are preterm birth, because you are doing an invasive procedure on the uterus, basically, before the baby is normally ready to deliver. And that's one of the downsides. Subsequently, there was 2 randomized trials that were performed in Europe that basically showed that the survival for severe diaphragmatic hernia on the left-hand side significantly higher in babies that had the balloon placement. For moderate-sized hernias, so hernias that are a little bit less severe, The survival was not significantly different, but one of the issues in this study was also that the balloon was associated with an earlier preterm delivery rate, and that might have precluded some babies to be actually eligible for curative surgery. Now, this is in Europe, so none of these equipments are available in the US unless you have approval from the FDA to bring them into the country. And that's done through a process that's called an investigational device exemption. So it does cost the center money. It does require regulatory oversight because everything needs to be very, very closely monitored. So although this is a treatment that's now available in the rest of the world as part of clinical management, in the US, we're still required to do this under an investigational intervention. And basically, we published our data 3 years ago on balloon outcomes. And when you compare to the literature, we have a lower rate of emergent balloon removal. We are able to remove our balloons more likely with just an ultrasound-guided needle puncture that is associated with a lower rate of rupture of membranes. Our average gestational age at delivery for babies undergoing balloons is basically a term, which means that it preserves all the therapeutic options, and our survival numbers are significantly higher than reported in the literature and certainly in the randomized trial. So when you actually compare outcomes of CDH patients in the US, with or without the balloon, they're actually better in terms of survival when you compare it to Europe. And certainly in the fetal centers that do the fetal interventions, that's where the survival chances are the highest. So that led us to sort of ask a few questions like why is that, So what is actually the optimal way to look after babies with CDH? And so the first thing that we really looked at was like, well, does the care setting matter, right? So here we have a fetal therapy center that has experienced fetal therapy staff and a pediatric program, and the patients deliver here and then get managed postnatally here. In the other centers where fetal is done, certainly in Europe, you have 10 to 12 centers across Europe that do the procedure, but then the neonatal management is about 40 centers that see a variable amount of CDHs, whereas in the US, that is not the case. Here, you can only really do balloons when you also have a pediatric program. So everything is integrated one side. So in a series of investigations, we've kind of looked at and we say like, well, this integrated program as we have it here is actually associated with a much higher chance for survival, as you see here. The other thing is our group is also the first one that sort of looked at what comes beyond survival. So if you look at patients that are managed in a multidisciplinary CDH clinic and studied there, we're able to show that the long-term outcomes are certainly favorable compared to patients that don't get a balloon. And more importantly for, as life goes on, the balloon and the decreased requirements for all the risky intensive therapies that are required after delivery is actually associated with a significantly improved developmental outcome. So that is something that's actually accepted for publication in the Journal of Pediatric Surgery. So our information or our knowledge has sort of expanded and has shaped our care path, where we say like, okay, we are doing the balloon. Our obstetric management allows more patients to sort of go beyond the balloon removal and experience a period of additional lung maturation. And when the baby is delivered at term, actually, the chances to have all the treatment options available and more mature lungs are even better. And we're operating very closely with a pediatric program where we learn from each other, And The FDA has now approved that we can actually convert our IDE to a prospective registry, which is quite a unique decision because normally that the FDA doesn't allow that, but the FDA is specifically interested that we gain further information on long-term benefits of the balloon that are not readily available from other programs yet. So this has been possible with gift support that has supported the salary of our regulatory staff, that has assisted with the meticulous oversight of these data. And this is one of the cards that I love remembering that I got from one of our patients that had a balloon and delivered, and the baby is doing great. So with that, I'm going to stop the sharing and, you know, open things up, and wanted to introduce our development team. So I think today the goal was kind of important to sort of give you some feedback what we have been able to do. The other thing that's important to recognize is that grant funding and financial support by federal agencies and the government and so on and so forth is typically focused on common conditions, you know, such as diabetes or hypertension, and fetal therapy is a small field. So we are in a situation where that's sort of a little bit of a sideline for the big funding agencies. And so any help that we have gotten in the past, I think we've been able to put to good use, and, you know, I'm very thankful for that. And one of the things I wanted to just hand over to Maddie from development to sort of go over the, you know, process of giving and how the supports the center. And then we'll sort of open it up for some Q&A. Okay, thank you.
Yep. All right. Thank you so much, Dr. Baschat. So just thank you so much to our physicians for sharing today. Those were excellent presentations. So as you've now heard, the faculty at the Johns Hopkins Center for Fetal Therapy clearly understands that the diagnosis of a fetal condition before delivery can be confusing and overwhelming. So that's why donor-funded initiatives like the ones that were shared today are so crucial in ensuring that moms and families are receiving the best possible care from the most experienced team. So much of that research that you just learned about would not have come to fruition without donor support. So that includes things like the establishment of the twin lab, the identification of laser techniques that double the survival rate of those diagnosed with TTTS, the identification of primary risk factors and new avenues for greater safety for fetoscopic laser surgery, staff support to sustain research, and also the jumpstart of the biobanking initiative. So there are a multitude of ways in which you can give back to the Center for Fetal Therapy, including making a tax-deductible gift online. And we'll drop a link in the chat for you to do that if you're interested. You can also become a monthly donor. So if you're not quite ready to give at a higher capacity, you can always make your gift go a little bit further by becoming a monthly donor to the center. And that can also be done through that same link that we'll provide in the chat. And you would just select the frequency of your gift as monthly. You can contribute through a donor-advised fund. So making a gift through a donor-advised fund allows you to maximize the impact of your gift by providing tax advantages and strategic giving flexibility. Using a donor-advised fund also simplifies record keeping, and it streamlines your philanthropic efforts. You could also make a planned gift. That's one of the most meaningful ways to make a substantial and a lasting impact. So by including a bequest in your will or trust to Johns Hopkins, you would play such a vital role in ensuring that the center really remains a global leader in education and research and patient care for generations to come. There's also stock and securities. So donating stock or securities offers the advantage of potential tax savings and the opportunity to support the vital work of the center while also minimizing your capital gains tax liability. There's also IRA contributions, which also provide the advantage of potential tax savings and also allows you to give back to the center while managing your retirement funds. So if you're not ready to make a gift, but you're interested in other ways of giving back, joining our Parents Council is another really impactful way to support the work of our faculty. The mission of the council is really just to support families diagnosed with fetal conditions by providing peer-to-peer outreach, supporting the physicians in being leaders in research that leads to improved treatment of fetal diseases, and also sort of serving as advisors to our faculty from a patient perspective, to really just provide the best care possible. So if you are interested in getting involved at all or providing support to the center, either through volunteerism or philanthropic giving, I invite you to reach out to our office at any time. So you can use that phone number or email listed here. And I just want to say thank you again so much for joining this afternoon. We are truly grateful for your participation. So please feel free to reach out to us with any questions. And I hope to connect with you all again soon. And I don't believe we've received any questions in the chat. However, you are welcome to reach out to us with questions after the facts, and we will be happy to get those answered for you. So thank you so much.
Are there any questions like verbally without the chat?
Yeah, feel free to come off mute.
Like, yeah. It's hard to ask a question when you're on mute. That's something I learned on Zoom.
That is tricky.
It's just typically the opposite, right? Not on you.
Hi.
Hi.
How are you all?
Good.
Good. First, I want to thank you all for everything you guys did to help my daughters and I. They're 15 months old and walking and talking, and they're amazing. So you'll getting a Christmas card this year. So be excited about it.
Thank
That
you.
we love. Christmas cards.
Yeah, they're amazing. So I actually had a question for Dr. Rosner regarding the you said something about the non-white patients have a lower survival rate with their twins. Do you guys plan on doing any more research to look closer at that? It's just kind of something I've always thought about in the back of my head. What if I didn't have the access that I had, or is it genetics, or anything you guys might have information on regarding that?
Yeah, I can share my screen actually just with that same slide. Of course, I closed it. It's not a good choice, but hold on.
I think, as Mara is looking for, or Dr. Rosner is looking for it, I think that's a really complicated thing to figure out properly. And one has to be like, we have to look at a lot of things to figure out what, because it is clearly insurance, it is geography, it is your local health access as well. Like, so there's a lot of factors that go into that, but just to put these numbers in perspective, right? The survival rate, like the percentages are cut off on the left-hand side, but what you see here on the rightmost column, like 2 survivors under 40%, 1 survivor about 25%, and 0 survivor 25%. Those kind of figures, they stem from a time when laser surgery was discovered, from the early 90s. So we haven't really seen that, and we are definitely I hand it over to Mara, but it is something important to look into,
Yeah, it's really staggering. I know that our nurse manager, Jen, is also planning a project, and Khadija Williams, the resident who works with the lab on this project, is definitely, we're planning a lot of work together on this. One of the things that we did think was interesting, though, is that the non-white patients who had commercial insurance, they did about as well as the white patients with commercial insurance. And so really the difference is in this problem, like you suggested, there is a racial disparity as well, but it's really profound when you see the non-white patients who don't have commercial insurance. And one of the reasons our nurse manager is getting involved is she works on the intake, right? She brings patients in, and there is a fetal therapy nurse network as well that she's really active in. And so she's also planning a project because she's really familiar with this issue where some patients, we get a phone call and the doctor says, I'm worried about twin-to-twin transfusion syndrome, patient needs a procedure, and we see them the next day because they don't have any insurance barriers and we can just bring them right in. Other patients, you know, because we have the ability to help patients, and we really never turn a patient away that I'm aware of because of insurance, but it takes us longer. So we either have to do like single case agreements, or sometimes if it's an emergency, we'll have them just come directly as an emergency to the hospital and present in that manner. And those are all resource demanding issues for all of us that we have to deal with you know, you're trying to bring people in who have barriers, and then arranging their follow-up care, which won't impact their laser survival, but may impact their birth survival, right? Because if they don't have as much care taking care of them after the laser, and we know that from our FETO data that Dr. Baschat presented, that the obstetric care is really critical too. So like Dr. Baschat said, it's very multifactorial. We are absolutely looking into this more. We really want to dissect the issue and try to make a difference. But as far as I know, there's only been a couple of published papers on disparities when it comes to fetal therapy. And so we're planning on changing that and making it more out in the open so we can start to see some change. But you're right.
Yeah. I tell you, honestly, having worked in an environment where there was no insurance boundaries, right? Because our laser center in Hamburg, we used to get cases from Norway, from Finland, from, you know, it was just they called and the insurances carry across borders, right? Because it was a recognized treatment center. I think what might actually have a huge impact in the US, if you said that fetal referrals are exempt from the medical assistance imposed state boundaries, right? Because that adds a 3-day delay on a rapid referral that sometimes is just not fast enough. You know what I mean? And so I would, there's a lot of things to be figured out, but you have to be careful when you sort of make statements like that, you know, that you back them up with reliable data. But I think it's an important thing. There was one question in the chat from Tara Radcliffe. How long, if any amount of time, do you follow families, twins who have had laser surgery with you, and what can you do with that data?
So you want to answer that or you want me to? I mean,
no, I'll have you answer it.
Sure. It depends. So people that come from really far away often go back earlier than people who are nearby. But we do try to send patients back to their providers because it's inevitably or almost inevitably more convenient for them. Patients who have ongoing complications, we will keep in our care until we feel they're safe to head back to their referring providers. Some people require cervical surgery that we'll perform for them, or we just do ongoing follow-up if they're having complications. But our goal is to get patients back to their referring environment if it's safe. And what you're bringing up is really interesting. We do have that data. That's something that we weren't able to have before we did the red cap, because it's hard to have all that longitudinal data of like every single ultrasound and every single follow-up. But now we do have that on our patients. So one of the projects that actually I didn't present that a member of the lab is working on, Jessamine, is looking at how, and we've worked on this before too as a center, but how patients resolve their TTTS after laser, which is something that you can only do if you have that long-term follow-up. So we're doing that, and that's one of the things we're doing with that data. That makes sense.
Hi, Dr. Rosner. This is Ching, mom for Shannon, Sharon, and Liz and Kate. We thank you so much for sharing the twin lab research. I saw there is a future research goal on growth restriction, and that's fairly very near and dear to my heart. I wanted to see if you can share a little bit more on that, and if there is, I was particularly interested to see if there is any research that can demonstrate predictions or even earlier in the pregnancy before anything shows the symptom of growth restriction that indicators that we can look for such that we can prevent even earlier, that might not have been, related to TTTS, but other placenta issues?
Yeah, so maybe the best answer I can also share, like Marissa's data that I didn't go that much into. Dr. Gilstrop Thompson did a project looking at patients who have TTTS, but what did their first trimester ultrasound look like, and are they at risk can we predict it based on their first trimester ultrasound? And she actually didn't find what we thought we were going to find. She didn't find that the first trimester findings were really predictive of a more severe TTTS or anything like that. But what she did find that we were not expecting was that first trimester findings, like an enlarged nuchal translucency, sort of the back of the neck measurement from 12 weeks, was actually a sign of impending fetal growth restriction more than anything else. And when we were surprised, but we went back and looked through the data, and there was actually one paper, very small numbers, showing something similar. So if we're looking at early predictors of growth restriction, that may be one of them to look further at. And the other piece that your question made me think about is our aspirin data, because we have been starting patients on aspirin for selective fetal growth restriction. That's when one twin is small and the other one is larger. And we've been doing that empirically based on the tremendous body of literature on aspirin helping with growth restriction generally in singletons. But publishing that data and looking at that data with twins and we started sometimes in the second trimester, would be a fantastic addition to the literature. How does starting aspirin early help? I know Dr. Baschat wrote, we've had other studies planned looking at aspirin, and there have been some barriers there, because all studies have these really incredible barriers that you would never think of. You get all excited and write a study, and then you're like, this is not going to be okay for whatever little reason that people find. But what we've been working on with the Twin Lab actually is really accurately recording when aspirin is started, if it is started in pregnancies with growth restriction, and having that down to the date. And this is a tremendous resource that we can learn from. And so the lab has not started the aspirin project yet, because we're still in the process of entering all the patient data on the selective fetal growth restriction patients, because there are a huge number of them, and that's a lot of data points. But that is a project we're going to be able to do. And every lab meeting, we say, like, any aspirin questions, and sometimes people will bring up, like, oh, this patient I couldn't figure out when they started aspirin, so we'll go through it. So that is a future project in mind. It is really big undertaking, but it's really exciting.
Yeah, thank you so much for sharing.
Yeah,
I have a story about that. So when I was in training in Germany, right, like a long time ago, we started making some observations on fetal growth restriction in singletons, right? And the thing was that the information that we needed was often in the scans that had been done in a referring physician. So we didn't have that, like, because we looked at a lot of things, and whatever happened before, we didn't have. So I had this one patient who, like, the baby had really bad growth restriction. And anyway, she came back the year after, and she said, like, I want to do some research with you. I'm going to go around and get these data for you. And she actually worked with me to get some information that actually helped to get some. I'm just talking about, like, when you ask, like, one of the hard things that we have, and that's why we have such a big twin lab, right? There's a lot of things that you've got to really work hard to get at, because, a lot of stuff is not recorded, or it's not clearly recorded. And, there's a lot of work to be done, so yeah.
Totally. I can imagine, like, when I was referred to, like, at 23 weeks, like, you probably would need to retrieve all the information I got with my OB, that maybe exams I have never actually done before, that probably should have, to predict. So I totally understand that. We do plan for to make donations this year, and would love to help in advanced research in the space. But thank you so much for sharing.
Thank you very much.
Hi, Dr. Baschat, Dr. Rosner. I just wanted to say thank you for everything that you guys have done and your research. And babies are doing great and have been watching your presentation. We're so thankful.
Yeah, love it.
Yeah.
Oh, I love it. It's so good to see you.
But yes, we will be keeping tabs and hoping to support you guys. Okay. Thank you so much.
So
Thank
sweet.
you.
Thank you.
Well, I think since the presentations are going to be recorded, and we can always send out maybe a link to the people that didn't have time to sign on and just sort of, listen to it and all that, if there's anything of interest. And of course, if there's ever any questions, you can always reach out by email or give us follow-ups. We love to hear from our patients, All right. Well, I think, am I the one who's concluding the symposium? I guess I am, because I'm the oldest on the thing, so I'll do that. Okay, I hope you guys all have a wonderful day. Thank you very much for, signing on, and yeah, all the best. Okay, hopefully we see you next year at the picnic. We're trying to have a really nice venue. Like, it's going to be outdoors, but it's going to be fun. Okay, bye. Bye-bye.
Bye, everyone. Thanks for joining.